Tobacco Prevention and Control, Tobacco Cessation in Teens. This is an analysis of the Not on Tobacco program by Rachel Markovich, PharmD. The Not on Tobacco program, or NOT program, is a development of the American Lung Association. The program's goal is to assist teen smokers in quitting. It entails 10 sessions of about 50 minutes each and covers all aspects of quitting. The classes are offered in small groups of same-sex adolescents with the trained facilitator of the same sex. The program is based on social cognitive theory, and gender issues are emphasized in the sessions. Since this program was developed specifically for teens, the language is relevant to teens. Classes involve group discussion, journaling, and tool-building activities. Students have the option of extending the course with 4 booster classes. Target population are 14 to 19-year-olds, smoking daily, and living in West Virginia or North Carolina. The NOT study sought to compare efficacy, or quit rates, of students attending NOT courses versus students attending a brief, one-time intervention session. At 15 months, the NOT program proved to be more effective. Overall, NOT offered a higher quit rate. Even though the program is effective, is it practical? Are the program components translatable to other regions? What kind of public health impact can be expected if this program were implemented nationwide? Let's explore the social factors involved. Rural youths are especially susceptible to effects of tobacco. They start smoking earlier and smoke more heavily. This study shows that NOT is also less effective in rural teens versus urban teens. Rural teens may have unique life experiences that the NOT program doesn't address. Various social factors are at play here. Rural youth are less educated. Overall, health education and access to services is probably lacking in these areas. Teen smokers probably have parents that also smoke. Smoking may just be a way of life for these folks. It's part of the culture. The efficacy data suggests these teens are resistant to change. This is a common theme seen among Southern politics. They favor tradition and tend to be fairly set in their ways. Tobacco farming in this area represents a large cultural acceptance of tobacco. Financial incentives for the tobacco industry make it difficult for opponents to intervene. The program is specific for teens, but the program may need to be further targeted for rural teens. Sessions may need to cover areas related to social norms of tobacco use, geographical isolation, and poverty. Across regions of West Virginia, more NOT program facilitators were trained than were offering classes, but this trend varied across regions. This also suggests that regional implementation issues need to be further examined. Geographical tailoring of this program could lead to higher success. Dr. Kimberly Horn is the principal investigator of the study. Her co-investigator is Dr. Jerry Dino. All authors of the study are with the Office of Drug Abuse Intervention Studies at West Virginia University. Dr. Horn and Dr. Dino are also associated with the Department of Community Medicine and the Prevention Research Center at West Virginia University. The West Virginia Prevention Research Center, or WVPRC, is one of 26 prevention research centers funded by the CDC, or Centers for Disease Control and Prevention, The WVPRC is housed in the West Virginia University School of Public Health. The mission of the WVPRC is to transform West Virginia public health policy and practice through community-engaged research and evaluation. They focused on conducting research on teens who smoke since 1995. The PRC formed a partnership with the West Virginia State Health and Education Departments, the Coalition for Tobacco-Free West Virginia, and the American Lung Association to develop a plan to reduce teen smoking, the NOT program. When discussing external stakeholders, it really encompasses the entire community. Many people could be affected by or affect this research. The mission of ALA is to save lives by improving lung health and preventing lung disease. The American Lung Association has a large stake in this research. Results from these studies are used to support further efforts by the ALA to encourage smoking cessation. The ALA of West Virginia provided training for the NOT program facilitators. The enthusiasm of these facilitators could have impacted participant success. Facilitators would assumingly favor teen cessation of smoking, but do these facilitators have any conflicts of interest? Are they involved with tobacco farming? The same goes for the parents. Do they view smoking cessation as a positive outcome that they're supporting? Study funds were provided by the West Virginia University Prevention Research Center from a cooperative agreement with the CDC. Funding was also provided by a grant from the West Virginia Bureau for Public Health Division of Tobacco Prevention. Of note, during the course of the study, West Virginia received a large sum of money for tobacco prevention through the Master Settlement Agreement known as the MSA. The NOT program was then implemented statewide as opposed to just selected schools, as the NOT program did. The MSA is a deal between the states and the 5 largest tobacco companies in America regarding the way that tobacco is advertised and promoted. The tobacco industry was required to pay out about $10 million annually to the states. The MSA also imposed restrictions on the sale and marketing of cigarettes. In my opinion, this study is ethically sound. I can find no major ethical implications with the implementation of this program. However, this study involves research of teenagers, and a few factors must be considered when discussing ethical implications. I find no record that parental consent was given to researchers. I also find no statement that informed consent was retrieved from participants themselves. Since these are minors, their parents have legal rights in making decisions. These parents may not have known that their child was involved in a smoking cessation program. Minors are required to have a parent or legal guardian present when seeking health care services. The researchers essentially only provided counseling. No medical interventions were made. But wouldn't a parent still need to be present if counseling services were received outside the school? It may have been prudent for the researchers to retrieve informed consent from the parents. However, these teens might not have participated if it required parental consent. Some teens are smoking without their parents' knowledge, and consent for a smoking cessation program would obviously reveal smoking status. I definitely see a large potential for opponents to this program. Obviously, the tobacco industry loses money if people don't smoke. The NOT program was implemented in the heart of tobacco farming areas. Tobacco farmers depend on the demand for cigarettes. A smoking cessation program could upset these economies. Rural youths smoke more and start smoking earlier than their urban counterparts. These teens are high risk because of the high level of poverty and decreased education levels. These teens that smoke go on to face significant comorbidities. Intervention with these teens was crucial to the researchers. At the time, very little was known about smoking cessation programs in this high-risk group. If I were attempting to get community buy-in for this program, my approach would vary based on the community. If I were marketing this program in another tobacco-raising area, I would run into some obstacles. In these regions, students' parents often grow tobacco and include the children in the production. Agriculture classes in school may discuss tobacco growing. Teachers in the school might themselves grow tobacco and rely on the income. To overcome these obstacles, I would address why specifically teenage tobacco use is a problem. I would emphasize that growing tobacco isn't wrong, but that teenagers need not participate in the consumption of it. If teenagers in this area watched a lot of television, I'd create a commercial saying that teens should think for themselves and not what the tobacco companies want for them to think. Or I could put posters up around the school about maintaining independence from negative social influences. I would meet one-on-one with the superintendent and principals, and then hold a group meeting with all teachers. School administrators could be persuaded by pointing out that health class teaches refusal skills for alcohol and drugs, and this approach can also work for tobacco. No statements will be made that people shouldn't grow tobacco, and no student will be made to feel inferior if their family is farming tobacco. Most parents would agree that minors shouldn't use tobacco. To market this program for the parents, I would have the school administrators assist in getting information flyers out to parents. I would appeal to them by pointing out how much healthier those children will be if they complete smoking cessation. I think every parent wants the best possible outcome for their child, and I can emphasize the health benefits of quitting smoking. In conclusion, the NOT program was successful because it achieved a greater quit rate than the brief intervention group. The program reached its intended audience of teenage students in West Virginia and North Carolina. Statewide enrollment increased each year. Also, the number of NOT offerings continued to increase, which indicates a continued interest in the program. Overall, NOT has been found to be cost-effective and adaptable. Short-term effects of this program are an overall decreased number of teenage smokers. These teens are able to breathe easier and experience a lower heart rate and blood pressure. The quality of life during the program may have been decreased due to the physical withdrawal symptoms and increased sensation of taste. Some teens may struggle with mild weight gain once their appetite comes back. We generally expect that teenage smokers continue smoking as adults. Long-term effects from smoking cessation can be hard to measure. Overall, we expect a decreased risk of oral and lung cancers, heart disease, and obesity. These teens are expected to live longer, healthier lives. The NOT program would be most adaptable to an urban or suburban area. When compared to other areas this program is implemented, rural youths achieved a lower quit rate. One would assume that non-rural youths are more open-minded about smoking cessation. The NOT program would need more location tailoring if trying to get success in another rural tobacco farming area. Increased program offerings from trained facilitators are needed to get a higher absolute reach. Facilitator distribution across the Appalachian regions were variable. A major discrepancy was found between the number of trained facilitators and the actual number of facilitators offering classes. More research could be done regarding the differences in regional implementation.